Hello friends, today I'll be talking to you regarding a very important topic, that is Acute Respiratory Distress Syndrome, what we call as ARDS in short. It is one of the most important topic in entire respiratory medicine. Throughout the world, whichever exam you write, you'll get a lot of question on ARDS, and practically also it's a very important topic in day-to-day clinical management, especially in the critical care. So I'll be integrating all the subspecialties which are relevant to my talk. Okay. Well, in this topic where we have some confusion, some important confusing point for most of students, we are not very clear about surface tension and surfactant. We are not clear about the PaO2, so-called partial pressure, and SaO2, so-called oxygen saturation, is very confusing to 99% students. We are not sure what is hypoxia and what is hypoxemia. Are they same or different? And what is FiO2, fractional inspiratory oxygen, are the usual confusing point. But don't worry, I'll make this subject very simple for you. At the end of the lecture, everything will be in your fingertips. With this small introduction, as my style goes, let's talk about basic anatomy. About the respiratory system, of course, of the alveolus to be more precise, which is relevant for my talk. So we start with basic concept about anatomy and histology. So we are well aware this is the trachea, 2 bronchi, then lot of about 22 or 23 more division, and finally we come to this is the end of the this thing, airways. So we have come to the final part of the airway, so-called respiratory zone. In this we have a respiratory bronchiole, and it is this which is going to open into the alveolar sac. The entire pathology of the ARDS is confined to this particular spectrum, and the other these are the areas which are involved in asthma and COPD. Okay, so we'll look into the closer view of the cell of the alveoli. Now this is a closer view. So this is the respiratory bronchiole. From air is coming and ultimately it is entering into alveolus, which is a cell, a sac. Let's look into the anatomy or histology of this. What is there? We have a type 1 pneumocyte. This is very important. And they are getting some flat cells. They are type 1 pneumocyte. And we have certain cells like this also, which are so-called pneumocyte 2. Okay. These are the two most important things that I need to tell you. What are the function? I'm going to discuss in a minute only. But don't forget, nearby is the blood vessel also. Of course, blood vessel means it is the one which is carrying carrying oxygen and taking away CO2. So now one more thing, when we say air is coming in, of course, the purpose of the respiratory system is to get air. Air means it contains oxygen. So entering of air and going out, this is so-called ventilation. And one more confusing, what is perfusion? Look into this blood vessel. These blood vessels are surrounding the alveolus, and they are coming and taking away the blood also. They are bringing the blood to the lungs and taking away blood from the lung. This is so-called perfusion. So alveolar duct is concerned with ventilation, and the blood which is coming via the blood vessel is perfusion. These terms I'll be using again and again. So with this small, now let me look into this closer view of this. Now let me show you a very close view of this, very simplified version. So we have these cells, so-called type 1 pneumocyte. And we have these cells, so-called type 2 pneumocyte, much better picture, I suppose. And these are the capillaries, so-called blood vessel. And we all know very well, in the normal alveolus, We have a macrophages, okay. Now, what is the function of macrophages? These are the defense cells. Defense cells, or you can say police of the body. What do you mean by police? Any pathogen, any bacteria or any pathogen which can come. Let's say a bacteria has come to this alveolus, and we have this macrophage cell which I showed you. It will simply engulf it. Engulf means, the medical word is phagocytosis. So it will engulf, it will do the phagocytosis, and it will kill the organism there and then only. Well, we all remember, we all know very well that our lungs are exposed to direct external environment. We inhale, lot of pathogens go in, but these macrophages, they destroy there and then only. So any pathogen has come, it has come here in the alveolar sac, and that will be engulfed by the macrophages. So at the moment in ARDS, we are very clear about it, what is the basic histology of a case of alveolus. Now, let me show you a closer view of these cells. Well, this is the so-called type 1 pneumocyte. What is the main specialty of the histology anatomy? They are squamous and extremely thin. Squamous means they are flat cells. Since they are flat, so they are extremely thin, and they cover 95% of the alveolar surface. And what the main reason, what the main function? They are the one which are involved in the gas exchange. Look into this. So we have this type 1 pneumocyte, which is a very thin layer cell, and here the blood vessel also. So oxygen will be coming in and the CO2 will be going out. So there is an advantage of thinness of the cell, that gas can very easily diffuse in and out. And these are, remember, these are 95% of the area of the alveolus is meant for the gas exchange. But we also have a type 2 pneumocyte. They are granular and roughly cuboidal. They are, look into, they are like cuboidal cells are there. Look into this. Here are the type 2. Okay, cuboidal. And one more thing, this is the, remember, this is all type 1, covering around 95% of the alveolus. So they cover, now the type 2 is only 5%, and they are the one which are meant with, they secrete pulmonary surfactant. So point to be noted, surfactant, which is there, which maintain the surface tension. What is that? I'm going to discuss in a couple of minutes only. So right now we got pneumocyte 1 and 2. So a quick recap of summary what we have learned so far. What is the function of type 1 pneumocyte? Gas exchange. Type 2, they are the one which secrete surfactant, and they reduce surface tension in the alveoli. This is the summary of what I have discussed so far. Now we talk about surface tension also. Well, what is this? Now we recall our school days when we read our physics, okay? In physics we were taught surface tension. What surface tension is? It's the tendency of the liquid surfaces to shrink into minimum area possible. Let me discuss in more detail. This is a water bubble. Yes, we have seen bubbles are made. If you look into a bubble, water bubble, what is it? Is a, of course, it is a very thin layer of the water. But in the water is air. That's why we call it as air bubble. Well, now this liquid or water, it has spread into a thin layer. A thin layer is there on the water, of course, that inside is air. Now, why the thin layer is made? Because of cohesive nature of the these molecules of water, they tend to unite to each other, so they make a cohesive type of picture like this. Okay, but they always have a tendency to collapse. They want to have the minimum area, and that is so-called surface tension. So friends, surface tension is a tendency of liquid surface to shrink into a minimum area possible. The air bubble which has been maintained by the air, they want to shrink it, and of course ultimately they shrink and ultimately they collapse also. Now surfactant, remember, in our body alveoli are there. We have seen the structure. They are simple air sac. Liquid lining is there. They also want to collapse. But we don't want the alveoli should get collapsed. And this prevention of collapse is done by the surfactant. And surfactant was produced by which cell? Pneumocyte 2. So surfactant are the compound that lower the surface tension of alveolar, hence they prevent the collapse. What do you mean? Let me give you a day-to-day example. This beautiful building is there. A very heavy roof is there. But the pillars are there. And these pillars, they prevent the collapse of this roof. So you can say they are just like surfactant. They prevent the collapse of the building. Okay. So same thing exactly in our body also. Again, same histology. We have a type 1 cell. Yes, we have seen, we know this type 1 cell. We also know this is a type 2 pneumocyte. It's a type of cuboidal cell. This is a what? This is squamous cell. Now look into, here we have a lining of surfactant. Surfactant lining is there, this one. And it is this surfactant which will prevent the collapse of this alveolar sac. Well, we have a one condition in pediatric, respiratory distress syndrome. It is often seen in the premature child. Okay, those preterm babies, in them, this surfactant is not well developed. This is not well developed. With the result, definitely, if the pillars are not there, the building will collapse. That's the basic aspect of pediatric, that why respiratory distress syndrome develop in the newborn premature child. Surfactant deficiency is there, right? So what we learned so far, we got surfactant in the body which is made by pneumocyte 2, and the purpose of this is to prevent the collapse of the alveoli. That's why they are maintained like a sac. If this alveolar will collapse, there will no air entry will be there. So we are clear about the surfactant also. Now one more confusing thing is oxygen saturation and partial pressure. Let's take one by one. Basic concept, physiology of arterial oxygen saturation, so-called SaO2. What is this? We are well aware we have a hemoglobin, and it get attached to oxygen, and that make HbO2. This is so-called oxygenated hemoglobin. We also know very well that when this HbO2 goes to tissues, in the tissues it releases the oxygen, and then what we get is HHB plus O2. This is what we call as oxygenated hemoglobin, and this what we call as deoxygenated hemoglobin. So in the tissue oxygen release, and this is deoxygenated hemoglobin is getting produced. Okay. Let me give you a little bit more basic physiology, then you'll understand much better about oxygen saturation. Suppose there are 100 molecules of hemoglobin, and in the lungs they get oxygen. We all know very well that Hb get attached to oxygen in the alveoli, and they go to tissues where oxygen is delivered. That tissues, they take away the oxygen, and 70 O2 molecule have been released. So how much left? 30 HbO2, and 70 will be deoxygenated hemoglobin which have lost the oxygen. Now again they come to lungs, oxygen taken up, and again this become 100 from where we started. So what you notice in the lungs, you get mainly you get oxygenated hemoglobin, and in the tissues it is mainly oxygen release, and whatever way in the veins which are getting the blood to the lung, we are getting more of a deoxygenated hemoglobin. With this background, we talk about oxygen saturation. So first of all, very important point, oxygen saturation is always taken in the arterial blood, not in the veins. Point to be noted. So in everywhere they write oxygen saturation, what we call as SaO2, but no need to say again and again it is we are talking about oxygenated hemoglobin in the artery, not in the veins. So now with this background, let's learn about what is SaO2. It's a measurement of hemoglobin oxygenation in the arterial compartment. It means, like in this I told you, suppose there are 100 Hb molecule were there. How many of them are oxygenated? That is so-called oxygen saturation. Like in this example, I told you 100 molecule of Hb, and every Hb molecule has a O2. So we say oxygen saturation in this condition is 100%. Got it? So normal oxygen saturation is 95 to 100%. So in the arterial system, whatever hemoglobin is there in a normal person, of course, around 95 to 100 hemoglobin they are carrying oxygen. So if you say 100 means everything, but if 95, we say 95% saturation is there, it means total Hb will be 95%, 95 will be HbO2 and 5 will be HHB if the saturation is 95%. The saturation is 95%, you got it. So total Hb is equal to 95 HbO2 and 5 are HHB. That means this is 95% saturation is there. Okay. Now very important point. So it is directly related to the oxygen supply of the organ. Definitely if oxygen is coming to the lungs or not, and ultimately it get oxygenated, and this HbO2 is going to all the organs, right? All depend how much Hb is there and how much saturation is there. Normal values 95 to 100%. And how we check? Pulse oximetry. What is pulse oximeter? It is utilized, and it's a small instrument. All of you must have seen now in the era of COVID, widely being used by the general public also. It's a very small, you just put into a clip like this, the way it has been shown in the finger, and this emits a light, specific wavelength light goes, and it can identify oxyhemoglobin as well as deoxyhemoglobin. It can identify. So remember, it can find out how much is oxy and deoxy. So suppose he picks up again 100 molecule, it picks up 95 are oxygenated, 5 are deoxygenated. So definitely you can say the oxygen saturation, like in this case, the 93% saturation is there. That means 93 molecules are HbO2 and 7 molecules are HHB. That I'm giving just presuming that it has picked up 100. So now you are clear about it, that oxygen saturation is. Now what is partial pressure of oxygen? And one more confusing thing. So again, basic physiology, we know very well that in the blood, oxygen is carried via attached to hemoglobin, the point we discussed, and that we measure as oxygen saturation. But some amount of oxygen is also carried by getting dissolved in the blood. But we know very well that oxygen solubility is very poor as compared to carbon dioxide. So whatever oxygen is carried by the dissolved form, this is so-called partial pressure. So my friends, this reflects the amount of oxygen dissolved in the blood. Okay, but again reminding you, the solubility of oxygen is much less than the carbon dioxide. So now what it really measures, partial pressure, and it is the effectiveness of the lungs to pulling the oxygen into bloodstream from the atmosphere. Well, this is the alveolus, from where the oxygen come into the alveolus, and here the blood vessel. So blood will be that oxygen will be entering the blood also, because some amount of oxygen get dissolved, so it can pull from the atmosphere, and ultimately once it remember, so it has to come and get dissolved, and immediately this oxygen will be picked up by the hemoglobin, and that will convert it into HbO2. So point to be noted that this is coming to the blood capillary, and of course once it enter, some amount will get dissolved, some amount of will get attached to the Hb also. So we are getting two components, and what is getting attached to Hb is the saturation, and what is getting dissolved here is so-called partial pressure. So we are clear about it. The normal partial pressure PaO2 is 75 to 104. Okay, and this is decrease in hypoxemia, very important point. So partial pressure is measured in millimeter of mercury, saturation is measured in percentage. Okay, point to be noted, it is up to 104 is the normal values, but saturation cannot go beyond 100%. Definitely there is nothing like 101% saturation. It has to maximum is 100%. So what we learn, let's have a summary of the physiology. What is ischemia? What is hypoxemia? What is hypoxia? Okay, this is the blood vessel. This is the tissue blood vessel. Suppose this have been totally blocked. Now total block, just what we happen in myocardial infarction. Artery is blocked, blood cannot go. So this is so-called ischemia. Loss of blood flow is ischemia. Agreed? What is hypoxemia? When PaO2 is less than, is decreased PaO2 is hypoxemia. Blood vessel, tissue, and the blood is coming, and we got dissolved oxygen, and this content is reduced, and dissolved content is reduced, what we call as hypoxemia. So dissolved oxygen reduced means partial pressure is reduced, we call as hypoxemia. Now blood has come to the tissue, blood is there and tissue, but due to any reason oxygen is not delivered to the tissue. This is hypoxia. It means ischemia, blood supply is not there. Hypoxemia, because dissolved oxygen is very less, and hypoxia, it is not able to deliver to the tissue, is hypoxia. So I hope things are clear to you regarding these three also. So Summary, again summary, one more summary. Partial pressure is oxygen dissolved in the blood, and it is 75 to 104 millimeter mercury. And what is the arterial saturation? Is a measure of hemoglobin oxygenation, and it is 95 to 100%. So these are the basic concept. Now I tell you some beautiful to make your subject very understanding. In anemia, hemoglobin concentration is reduced. Normal HB let's say it is 14 in males. In anemia, let's say 10 gram is there. So HB is reduced. So definitely, but saturation is normal. That means although HB amount is less, but whatever amount is there, they are doing that job fully. They will take up the oxygen. Dissolved oxygen is also normal, but total content reduced. Why? Because HB is reduced. HB is reduced, so total oxygen will be reduced total content despite normal saturation and normal dissolved oxygen. In polycythemia, where the HB is much more than, it may be around 20 gram per cent. Increase HB, saturation normal, dissolved oxygen normal, but total oxygen is increased. Why? Because the number of HB are increased. But what happened in COVID? HB is normal. Saturation is also normal initially, but the partial pressure is reduced and the total content of the oxygen is reduced. This is a unique thing that happened in COVID. Point to be noted, normally, so in this case, this is the oxygen saturation, and later on oxygen saturation falls. This is SaO2, and later on SaO2. But partial pressure in COVID, this goes down like this. Okay, PaO2 goes down. So what I want you to notice that for a good time, saturation in COVID remain normal and suddenly it start falling. Partial pressures start falling very fast. So that means a patient of COVID who has a normal saturation doesn't mean he will have a normal partial pressure. But one thing is definitely there, if the saturation is falling or started coming down below 95 or 92%, it is definitely a serious matter. And remember, this we can check by oximetry, the point I showed you. But remember, the partial pressure you check by arterial blood gas analysis. And ABG is a very expensive test to be done in a specialized laboratory only. Cannot be done at home. So that's why single best thing that to look into the COVID is oxygen saturation. With this background of all basic concepts, now we come to the subject of ARDS, and I'll be using the knowledge what we gain, but when I'll give you a applied, then you'll be understanding better. So ARDS, Acute Respiratory Distress Syndrome, it's a clinical syndrome caused by diffuse alveolar capillary damage. Okay. Leakage of fluid from capillary into the interstitium. Note it down. I'm going to explain to you in a minute only all detail. So first of all, it's a diffuse alveolar and capillary damage. And leakage of fluid from capillary into interstitium occur. ARDS is also known as acute lung injury. Why? Because it is a acute onset. Acute means sudden onset. Since lungs are the primary organ, so they are lung injury, what they call as. We also call as shock lung. Why? Because there is diffuse reduction in the lung function. We also call as diffuse alveolar damage, DAD, because almost majority of the alveoli are damaged. So there is a damage to whole alveoli also, we call as diffuse alveolar. We also call it to be non-cardiogenic pulmonary edema, because this time, of course, there's a lot of fluid accumulate in the lung, and the accumulation of fluid is in the interstitium, and it is not related to any cardiac condition, and that's why we call it as non-cardiogenic pulmonary edema. We also call it to high altitude pulmonary edema, because those of some of the people who go to great height like Himalayas or Alps, etc., those who go to great heights and they develop this type of problem, so-called high altitude pulmonary edema, is same a type of ARDS. Okay, so all are same. All these things I'll be discussing in coming slides. So now we learned the basic. So ARDS is clinically characterized by rapid onset. We understood the meaning. That's why we use the term as acute onset. It's a life-threatening condition. That's why we use the term as, this was for acute. Distress. Distress means he is gasping for the air. Life-threatening condition. It is a respiratory insufficiency, R. R is for the respiratory insufficiency. So now you understood the meaning of acute respiratory distress syndrome. Cyanosis occur in the late stages. Cyanosis occur because of severe oxygen deficiency, and definitely hypoxia will going to happen. But what is special? This hypoxemia is refractory to oxygen therapy. This is a very, very important meaning. Write down. Even if we are giving oxygen, the patient is not responding. Why? That is the basic pathophysiology which I am going to discuss in the coming slides. In the later stages, multi-organ failure occur, and that's why in such cases they have a very high mortality. Not only the lungs have failed, mortality is very high mortality. So initial thing, pathology start with a respiratory failure, and later on multi-organ failure, kidney failure, liver failure, and that's the reason why they have very high mortality is there. So now we talk about pathophysiology of ARDS. Once you understand the basic pathophysiology, you will understand everything very clearly. So here is the alveolus, A. A is the alveolus, okay? Alveolus. Here is the capillary. C for capillary. And we also know very well, normally oxygen goes like this and CO2 comes like this. That we know very well. And PaO2, that means the partial pressure of the oxygen here. And PaO2, that is the partial pressure of oxygen in the blood. This is normally much higher. This is much higher than this PaO2. Normally, when we are breathing inside, okay, we are inhaling, air is going, oxygen going, the partial pressure is high. So that's why high pressure goes to the lower pressure zone. And the moment it enters the alveoli, and there are two things which are there. Hemoglobin is there to grab it, and some amount of oxygen little bit get dissolved into the blood also. And what I told you, whatever this HB is taking it becomes HA2, that is going to increase saturation. And some is getting dissolved into this, and that is going to increase the partial pressure also. We understood. CO2 will go out, clear. Now, what happened in ARDS? In ARDS, the initial injury is this leakage of protein fluid. There's a breakage of the capillary lining, and the protein-rich fluid comes into the interstitium. Now, the whole interstitium is full of this protein-rich fluid. This is the beginning, and later on, these alveoli or alveolar membrane also get damaged, which I'm going to discuss in a minute only. But before I discuss the pathology, let me tell you, this is the initial stage. The entire interstitium is full of this protein-rich fluid. Well, now the air is coming here. Air is coming here, or I say oxygen is coming here. Now this whole interstitium is full of these necrotic material, protein-rich is there. And we know very well, in our school days, we were taught that oxygen is a by and large water insoluble gas. That's why I've been telling again and again that amount of oxygen which is there, dissolved oxygen is very, very less in the blood, but still important, which is creating partial pressure. But here it is full of these protein-rich fluid, so oxygen cannot go in. It cannot go in. That's why this in the blood is, so there is no oxygen coming into the capillary. So what happened? There will be reduced oxygen saturation. Yes, no oxygen coming. HB is not getting any oxygen. No oxygen coming into the capillaries. Whatever little bit of oxygen get dissolved, even PaO2 will also go down. Both will be reduced in ARDS. So that means total content of oxygen will be reduced in ARDS, and they are taking the blood to the whole body without any oxygen. So that's why blood will be going. Blood will be going. There is no ischemia as such, but there is no oxygen. So that lead to hypoxemia. No oxygen going there, and they are not able to deliver to the tissue, and that will lead to tissue hypoxia. So now you can use the knowledge of, so there in these cases, blood is going, there is no ischemia, there is no reducing in blood flow, but they are not carrying oxygen, hypoxemia, they are not able to deliver to tissue, hypoxia. The definition, I hope you remember. But CO2 can very well go out. Why? CO2 is a water soluble gas. It can very well swim out. So in net result, there will be reduced of PaO2, and there will be reduced PaCO2. CO2 pressure will go down because it can go out, and this is the reason why in this patient you get type 1 failure. Type 1 failure means reduced PaO2, reduced PaCO2 is the hallmark of type 1 failure. One more thing, in this case, this is the PaO2. PaO2 is the partial pressure in the alveolus, and the PaO2, small aO2, is the partial pressure in the capillaries. This oxygen is not going, so this remain high, this remain low. So that's why in these cases PaO2 gradient, PaO2 will be increased. The gradient will be increased because alveolar oxygen is not coming to the capillary. So that's why the gradient will be maintained. Gradient will be maintained like this. So this is the scenario. So friends, so now we talk about what happened. So there is a diffuse, now you can write down, diffuse damage to capillary, alveolar capillary interface, and there is also damage to alveolar damage also. Later on, this was the normal alveolus, capillary leakage occurs. Later on, even this get also destroyed, and here lot of proteins will be there. Surfactant will be reduced. Why? Pneumocyte 2 are damaged. So that means whatever surfactant was there, it is not there now. They will collapse. So alveoli will collapse, and that lead to alveolar collapse. So you understood, these are going to get, so they will become like this, collapse. This is the blood vessel, the collapse. So alveoli are collapsed, and even later on these lining will get damaged. So ultimately, and I told you this increased capillary permeability, lot of permeability is there, leakage of protein rich fluid is coming. So in the interstitium, leakage of protein rich fluid into alveoli and the interstitium, and now this rich protein, it will make a hilar membrane. So this will become like a membrane. This all the protein, it will get coagulated. Coagulated protein will be there. Well, if you want to see know the exact meaning of the coagulated protein, you all must have seen the eggs. Okay, yellow of the egg and the white, and if you boil it, it totally become coagulated. Okay, same thing here also. This protein become coagulated and it become a stiff. Remember, this is just like the boiled white egg. Here also it is like a white egg boiled. So now it is in the interstitium. We can all take a deep breath. We can expand our lungs because of what? Elasticity of the alveoli of the interstitium. But now it is full of water, liquid, protein-rich fluid with a coagulated protein. The lung will reduce the elasticity. That's why we call this entity as stiff lung. We call as stiff lungs. Why? The lungs have reduced the elasticities there. Okay. So ultimately, what I told you, a protein-rich fluid accumulates in the interstitial space as well as the alveolar space also. Why alveolar space? The alveolar wall, which is made of the pneumocyte 1 and 2, they are destroyed. So now whole thing is full of the non-protein, and we call it non-cardiogenic pulmonary edema because the pathology is not related to cardiac, and it is all due to local problem. And the main thing what is in this case, left atrial pressure is normal in these cases. In cardiac pulmonary edema, left LA is left atrial pressure is increased. Here the left atrial pressure is normal. This is one of the most important thing what they ask. How will you differentiate between cardiac edema and non-cardiac edema? Is left atrial pressure. Okay. So ultimately membrane is formed, which is composed of fibrin, protein and dead cell lining and coagulated protein. All are making the membranes. Okay. So we are getting hypoxia, decrease oxygen saturation. We are getting hypocapnia because CO2 is going out, and that's why what we call it, we get type 1 respiratory failure. Summary of now let me tell you summary of pathology. We are getting pulmonary edema and hyaline membrane. Hyaline membrane has been formed by fibrin and coagulated cell debris in the interstitium, and that lead to reduced lung compliance, so-called stiff lung, and tidal volume is reduced. The lung cannot expand. The reduced tidal volume will be there. This again a very important point. What is tidal volume? Is the amount of air that goes in and out in each breath is a tidal volume. Okay, so tidal volume is reduced in this case because of reduced elasticity is there. So this is a summary of the pathology. So a quick recap so far, which is the so-called difficult part. There's a damage to alveoli and there's capillary also. If protein-rich fluid accumulate in the interstitium and oxygen cannot go in, but CO2 can come out. So we are getting type 1 failure. With this background, if you talk about pathology, we have a exudative phase, 0 to 7 days. It is this when the hyaline membrane is formed. Proliferative phase, 7 to 12 days. Here we have lot of inflammatory cells come in. Fibrotic stage after 21 days, mostly patients recover or die. Some people develop lung fibrosis. And in ARDS is a sequelae in some of the patients of COVID also. Okay, in COVID patient, they are developing ARDS, a type of ARDS. Many are recovering, somehow die also, but many are developing fibrosis also. Why? The final phase is lung fibrosis. How come? Again, you go back to basic histology. I showed you this picture. This was the type 1 pneumocyte, this was the type 2 pneumocyte, these were capillaries. But there is one more thing, fibroblast is also there. This is a normal finding. Deliberately that time I did not highlight it. Now time has come. So we have a fibroblast. So it means the initial stages, this is gone, this is gone. Okay. And later on, when the fibrotic stage comes, they start making proliferation and they do develop the lung fibrosis. So now, once lung fibrosis are almost a fibrotic tissue, lungs are damaged forever for those who develop lung fibrosis. Okay, so we are clear about the pathology also. So now let me show you some of the pictures also. This is what we get in ARDS. You can see diffuse ground glass appearance. Oh, this is a much better picture. This is the X-ray and CT scan, ground glass appearance, the typical word we use. Okay, look into this diffuse alveolar pattern. Well, so we got one patient. Let's go back. Alveolus, capillary, and the interstitium is full of these protein-rich fluid. This is a basic pathology in the most simplified way. And normally oxygen goes like this, CO2 comes like this. But here this component is affected, oxygen cannot come in. Well, so with this, as oxygen is not coming to capillaries, severe hypoxia is occurring. So now my aim is to give oxygen to this patient. Even if I give oxygen by so-called mask, face mask, oxygen will come up to this place. That means ventilation will be there. You remember in the very beginning I told you whatever oxygen is coming to the alveolus is ventilation. Whatever blood is coming here is perfusion. So here ventilation is occurring, perfusion is occurring, but oxygen is not going. This is so-called ventilation. Perfusion. Mismatch. Mismatch means oxygen coming and not going. Is the classic example is ARDS. Well, I want to give oxygen, but even if the oxygen comes, it cannot go in. But before I discuss how to deliver oxygen, let me give you one more basic concept about very confusing. We'll talk about FiO2. FiO2. FiO2 is fractional inspiration of oxygen. What is this? Normally, we all take 21% of oxygen from the atmosphere. We know it very well. Even a schoolboy knows it. In the scale of 100, we take 21%. About 78 to 78% is nitrogen. That is well known to all of us. So in the scale of 100, it is 21. In the scale of 1, it will be 0.21. And this is known as FiO2. So normal FiO2 is 21%, or in the scale of 1 is 0.21. Normal FiO2 is 0.21, rounded off to 0.20 for easy calculation. Now, presuming the partial pressure of A2 is 100, I told you it is 75 to 104. But again, for easy calculation, I am taking 100. So, normal PaO2 is 100. Normal FiO2 is 20. The ratio becomes 0.20. It becomes 500. The ratio is 500. This is the basic concept. Now, in ARDS, what happened? What I told you, PaO2 is going down. Remember, saturation going down, PaO2 going down. Let's say now PaO2 has, normal was we have taken 100. The PaO2 has gone to 60. PaO2 60. You divide by 0.20. Ratio becomes 300. We call as mild ARDS. It has gone to 40. More hypoxia. That means more hypoxemia, to be more precise. PaO2 has gone to 40 from 100. Ratio is 200. Moderate. And PaO2 has gone to 20. Severe. 0.2. This becomes 100. So this becomes severe ARDS. So we classify ARDS into mild, moderate, severe depending on the ratio. PaO2 FiO2 ratio is there. Well, we are clear about it. So we understood the problem. What has happened? The problem is, in a nutshell, lot of protein-rich fluid in the interstitium. And second point, and that is causing hypoxia, is a summary of what we have learned so far. Let's see what are the causes. There can be a direct lung injury, pulmonary. Pneumonias and COVID are the major thing which are the cause of ARDS. Gastric aspiration, any content of the stomach can come to the mouth and can be aspirated in the lungs. Toxic gas inhalation. Suppose a person is made to stand in a place where a lot of toxic gases are there, that can again induce ARDS. Huge list is there. Okay, but there are at least 100, more than 100 causes are there. Do you need to remember each one of them? No way. Don't forget these three. Direct and indirect injury. That means due to any systemic illness. Septicemia is the most common cause. And in this septicemia, again, it is usually the lung septicemia, pneumonia, COVID, which can induce septicemia later on. They are the ones which are going to cause ARDS. Shock, pancreatitis, acute liver failure, so-called fulminant liver failure, can lead to ARDS, malaria, especially cerebral malaria, caused by Plasmodium falciparum. And drug or toxin, heroin toxicity, it is such a commonly asked question. We all know very well that heroin is a type of drug abuse. It's a very common cause, a very commonly asked question throughout the world. So whenever they talk about a a drug abuse, a drug peddler is there who consume addictive, and then ARDS means he's taking heroin. So they are some of the one important causes, but again at least 100 200 are given in the books. How the patient come to us? Tachypnea is one of the very obvious feature. Tachycardia, pulse rate is very high, increase in the respiratory rate, increase in the pulse rate. This is a very obvious finding, and you can see the patient labored breathing. He is really gasping for the air. Can you think what the reason? Because lungs are total solid. There is no elasticity. He is not able to take the oxygen. He is getting hypoxic, and that hypoxia will induce the breathing, tachypnea, and he will have labored breathing. You can see from a distance he is gasping for the air, and later on cyanosis can occur. Fever may be there if the patient has any septicemia. Okay, cyanosis, and later on multi-organ failure occurs, and that's when the multi-organ failure occurs, the mortality rate goes very, very high. Now, what are the diagnostic criteria we talk about? Acute onset less than 1 week. That's why I've been talking acute onset, though we call it acute respiratory distress syndrome. Duration is less than 7 days. Patient was perfectly all right a week before. Now that suddenly he has the problem we call as ARDS. If you now we do chest X-ray, we have seen plenty of chest X-ray. Bilateral pulmonary infiltrate, what they call as white out on X-ray. You have seen the X-ray. White out on X-ray is a diffuse. Look into white, total white. Total white is there. See this. What the word they use is white out. White out. Okay, white out on X-ray. Pulmonary capillary wedge pressure, which is nothing but an indirect measurement of left atrial pressure. Atrial pressure, this is normal, below 18 millimeter mercury. In cardiac pulmonary edema, this is more than 18 millimeter of mercury. This is a universal exam question, how to differentiate between the two. Cardiac and non-cardiac pulmonary edema is LA pressure, so-called pulmonary capillary wedge pressure. Partial pressure of oxygen to fractional inspiratory ratio, that is PaO2 FiO2 ratio is less than 300. So they are the so-called point by which we can say they are the diagnostic criteria of ARDS. How to manage? This should be managed in ICU. Those ICU which we have a ventilator facility must be there. Why? So such cases should never be managed in the wards or even any ICU with no ventilator. It should not be managed. It should be, the ventilator is mandatory. Why it's so important to talk about ventilator? So for that we go to basic. So we got a patient of ARDS with lot of this material in the interstitium. Of course alveoli are also damaged, but at the moment I am showing the picture for easy convenience. We also know that oxygen come up to this level, we call as AO2, and it is PaO2 which has to take oxygen, but oxygen cannot come in, it's a water insoluble gas. Okay, now what to do? And remember, if the ratio is 100, if PaO2 FiO2 ratio is 100, okay, that means PaO2 has gone to 20 millimeter of mercury from 100. He is severely hypoxic, he will die in a couple of minutes only if you don't take care. But the problem with me is, as a treating physician, I can give oxygen up to this place. Now what to do? Now I'm thinking. Suddenly I recall my again school days. In school days, in our physics and chemistry, we were taught that if a gas is put under pressure, its solubility increases. Oh, fine. I will use that knowledge in managing. I will put this patient on ventilator. And there are two types of ventilator. One is the volume ventilator. Other is pressure ventilator. What we call as PEEP. PEEP stands for positive and expiratory pressure. So positive and expiratory pressure, if I put into PEEP, it will push the oxygen with a greater pressure. It is a positive. It will put a pressure, great pressure. And with the great pressure, this oxygen will get dissolved and go in. Can we think of any example of that gas under pressure? Yes. You all must have opened the bottle of soda bottle. Soda bottle is there, you just open it. The moment you open, you find the all gas comes out. You can visibly bubbles are coming up. Why that? Because in that soda bottle, the air was dissolved under pressure. And once the pressure is opened, removed, a whole thing comes out. Same thing, you look it if you open a bottle of beer also. Do I need to tell the whole that bubbling? So purpose of telling you is in this the pressure is there. So same knowledge we are using. We put this patient on ventilator. That's why I've been telling. So I laid a lot of emphasis. This patient should be managed in an ICU where the PEEP is there. So by this oxygen will go in, and that will increase the oxygen saturation as well as the partial pressure of oxygen. Fine. What else we can do? Well, let's say the FiO2 is 0.2. Let's say it is one ventilator, it is pushing 2 molecules of oxygen, one more ventilation, 2 oxygen, 2 oxygen. With every time 2 oxygen molecules are pushed, just for an easy example, because FiO2 is 0.2. Now if I increase FiO2 to 0.4 with this 4 molecule, 4 molecule, 4 molecule. Now the number of molecules going inside will be double if I increase FiO2. So friends, that's a basic principle. So with this background, so this patient should be managed in the ICU. Supportive therapy in the form of routine, the moment patient comes in, IV fluid and whatever support, antibiotic, and treat the underlying cause, whatever cause is there. Okay. Different causes, the list I gave to you. In early ARDS, we can use CPAP. It is a non-invasive, just that you apply CPAP, it gives the oxygen with the pressure, but we don't have to intubate. We give 40 to 60% oxygen, that means we are giving increased FiO2. So FiO2 we are increasing right in the beginning when CPAP is given, and give antibiotic to take care of sepsis, the most common cause. Nutritional support, simple. Steroid may improve outcome in some cases of ARDS. But here come the most important from exam point of view, practical point of view also. But majority of the patient, you need mechanical ventilation. And what I told you was positive and expiratory PEEP, what I mentioned. And I also mentioned you what the basic principle is going to push the oxygen under great pressure. and we also increase the FiO2, we increase the basic concept. We can go up to 0.6, but if you go above 0.6 of FiO2, that can lead to some sort of oxygen toxicity also. So that's why up to, for all the cases around FiO2 is maintained between 0.4 to 0.6, right? One more thing, very, very important point. You give low tidal volume. Why? We don't want to push too much of air. We don't want to increase the volume. The moment you increase volume, the lungs are stiff. If you increase the volume, lung will burst. In a small balloon, if you put lot of air, that balloon will burst. The golden rule is low tidal volume. It should not be more than 6 ml per kg of the ideal body weight. So low tidal volume, LTV, low tidal volume ventilation. So in nutshell, if I have to give you summary of ventilation, it should be number one, summary. You can write down summary of how to. Number one, use PEEP only. Number two, you can increase FiO2. And third, low tidal volume. This is 3-word summary of the entire ventilation about ARDS. PEEP, increase FiO2 and low tidal volume ventilation. Well, our aim is to maintain the partial pressure of 55 to 80. We don't want to go up to 100. Even up to above 55 also we are happy. We want oxygen saturation 88 to 95. Okay. So point to be noted that we don't want it to be 100%. Okay. So we want near normal of partial pressure and SaO2. But still overall mortality is 50 to 75% depending on what's the reason. And moreover, the mortality is very high in those patients, those who have a lot of comorbidity like diabetes. In such cases, mortality is more. Now, one more thing, when we use the ventilator. Now, these are the gold medal question. If you want to increase oxygenation, you can increase FiO2 and you can increase PEEP. You can increase the pressure. This what we have done in a case of ARDS. We wanted, our problem of the patient is less oxygen. We just want to push oxygen. Now, this is if you want to give oxygen. But we want that carbon dioxide should also come out. And this happens especially when the body retains a lot of CO2 in type 2 respiratory failure. And there we want to increase ventilation, more oxygen goes in, come like this thing. Then we increase the respiratory rate and we increase the tidal volume. This is to increase the ventilation when you want to remove CO2. You want to give oxygen, give FiO2, increase PEEP. And of course, these are not to be done in ARDS. In ARDS, our aim is to increase oxygenation only. So a quick recap of the ARDS. We call it the acute lung injury. Why? Because whatever happened within 7 days, it happened. It's ARDS. Non-cardiogenic pulmonary edema. Why? There's nothing, it's not related to cardiac condition. That's why we call it non-cardiogenic. But we call as pulmonary edema. Here also, like cardiac pulmonary edema, lot of fluid is there in the lungs. But it is all protein-rich fluid. There is additional damage to alveoli also. Capillaries are leaking lot of protein-rich fluid and there is a damage. Why damage to alveoli? Because pneumocyte 2 are damaged and there is reduced surfactant. Alveoli collapse and later on alveolar wall are destroyed. Important causes include septicemia, the most common cause, liver disease, acute fulminant liver disease, Plasmodium falciparum, heroin toxicity. High altitude, those who go to great heights, they tend to develop ARDS. Why? In a very height, the atmosphere has very less amount of oxygen. So we can say, if I have to tell you high altitude pulmonedema, there normal FiO2 is reduced. Why? Oxygen content is reduced in the height. So somebody asked you natural, where the NECA, we talk about 21% of atmospheric oxygen. But in the great height like Himalayas or Alps or big height, the FiO2 is naturally reduced. The classical finding is sudden onset of dyspnea and labored breathing. The typical word they talk as labored breathing. He's gasping. He's gasping for the air is the one. And the pathology, accumulation of protein-rich fluid in the interstitium. And this due to this reason, oxygen is not going from alveolus to alveolar capillary. LA pressure is normal. That's one point by which we differentiate from cardiac pulmonary edema. We get type 1 respiratory failure because there is hypoxia with hypocarbia. But in the late stages, there can be type 2 failure also. In the late stages, cyanosis develop. They are all late feature. And reduced compliance, that is lung is not able to expand. Why? It is stiff lung. The interstitium is totally stiff, full of protein rich fluid. That's why we get stiff lung. FiO2 ratio is less than 100 is severe ARDS, but the diagnostic criteria for ARDS is less than 300 is ARDS, but severe is less than 100. Management, treat the basic cause. We gave antibiotic, we gave all supportive measure. Low tidal volume ventilation. Okay, never give high volume, otherwise that lead to barotrauma. What the word they use is barotrauma. Lung will burst. So use low tidal volume and use what type of ventilation? You use PEEP, positive and expiratory pressure is needed. We don't need volume. We don't need volume, we need a pressure so that it can dissolve the oxygen, whatever it is possible is there. Okay, and finally, you can increase the FiO2, you can go from 0.2 to you can go to 0.6, but beyond that it is not recommended. So this is all about ARDS. Okay. Thank you very much. God bless all of you.